So we are honored to have all of you staying with us so long, and we're particularly honored to have Senator Sheldon Whitehouse here with us, who has been an innovator in the payment areas and the reform of reimbursement for many years. And that's essentially what we've been talking about all day today, is how do we take these innovative new therapies, but also equally innovate on the payment and reimbursement and the healthcare side to move forward. One of our themes has consistently been data and how important that is. The Senator has been a leader in providing funding and innovative approaches to embed information technology within the healthcare delivery system. We've talked about pooling and different ways to treat patients in need in special ways, and whether it's been in behavioral health or in the opioid area, the Senator has again been a leader in how to tailor the healthcare delivery and reimbursement systems to meet those particular needs. So without any further ado, Senator, we would love to hear your comments today about gene and cell therapies. Thank you so much for joining us.
I'm sorry to interrupt your panel discussion just as it was getting to the best part. You'll have to follow up with them later to find out what you missed. Thank you for letting me interrupt, though. I do appreciate it. It is a very, very busy day up at the Capitol. We have an agreement. The Eagle has landed. There will not be a shutdown. It may take a while to have our sizzling hands communicate to our brains that that was a really stupid hot stove to lift. But I do think the message has sunk in. So thank you. Mark, I appreciate the kind introduction, and I want to thank the whole team from MIT NEWDIGS for inviting me here today. I know you heard earlier from Senator Cassidy, and I want to take this chance to recognize him for being a very thoughtful, bipartisan partner for me on many of the healthcare challenges that we are tackling in the Senate and on the Finance Committee. Gene editing and other unheard of technologies just a few decades ago are forcing us to rethink the way we treat disease and the way we pay for it. Cell and gene therapies are giving us the opportunity to cure diseases that we could once only hope to manage. But as you all know, our healthcare payment system isn't built to accommodate the significant upfront cost of many of these innovations. The first CAR T cell therapies came to market with price tags of hundreds of thousands of dollars, which presents a serious challenge for both coverage and for cost. How are insurance companies and plans supposed to bear that cost? And will they? And if they do, how much of the cost does the patient end up responsible for? Medical innovations help no one if patients ultimately can't afford them. Changing the way we pay for healthcare is essential across many areas, and it has proven to lead to improved quality of care. We have spent a good deal of time and effort working through value-based payment models for healthcare professionals and hospitals. I would say we're still only at the very beginning stages, but the early response and the early results have been very promising. One lesson from that effort that I would urge you to keep in mind is that improving health outcomes while reducing healthcare spending is a goal that Republicans and Democrats share. We have been in repeal and replace Death Valley for quite some time in the Senate, in which it was very hard to have any conversation about healthcare that did not immediately devolve into a tribal fight over whether to repeal Obamacare or not. That cloud has lifted. It actually, I think, lifted with the failed vote to repeal Obamacare. But the fact that there's a Democratic House now puts an emphatic exclamation point on that closure. So I think that opens up policy conversations in the Senate that were not feasible before. So as you get closer to considering policy recommendations for us in Congress, engage us. Engage the experts that we use, engage the members from both sides of the aisle. You will get differing perspectives, I can assure you of that, But those different perspectives will help you develop pragmatic solutions and see what obstacles might be ahead. Having bipartisan buy-in does go a long way to a warm reception in Washington. Right now, there's a lot of bipartisan energy in Congress to fix a related aspect of the health system, how we pay for prescription drugs generally. In the Finance Committee, Chuck Grassley and our ranking Democrat, Ron Wyden, have announced that tackling high drug prices will be a priority. And we've already completed the first of what I expect will be a series of hearings on this important topic. One of the central questions of the drug pricing debate is how we can lower prices while maintaining incentives for innovation and protecting patient access. Today, you all are considering how a system can pay for an expensive new drug rather than how it can bring drug prices down. But I think some of the same considerations apply. We don't want to stifle innovation happening in curative therapies, but we also need to ensure that those innovations will actually get to the patients who ultimately need them. I am excited about the pilots being launched by MIT to test milestone-based contracts and other creative ways to pay for therapies. These payment models represent a fundamental shift in the way we think about paying for value, and they aim to help the market bear medical innovations. The willingness of private sector players to participate in these pilot programs is a good sign. It shows me that there is real interest in rethinking the current system. I think the results of these pilots will be very valuable to policymakers legislatively and on the executive side as we seek sensible reforms. Of course, there are always regulatory barriers to developing new models like this. Medicaid, best price requirements, and anti-kickback regulations make it difficult for payment innovation to keep up with medical innovation. Given Congress's current focus on drug pricing, though, it's the perfect time for invested parties like you all to make the case for updating these regulations. There are many sympathetic ears. Any changes will need to maintain these regulations' intent of keeping costs down and maintaining a level playing field, but it's certainly a conversation worth having, and I believe Congress is ready to listen. As the largest purchaser of health care in the United States, the federal government needs to lead the movement to form new and better ways to pay for treatment. As Secretary Azar said at his Senate nomination hearing, Medicare is the only payer that sits there with enough concentration of lives to change the system. Once Medicare, enabled by new authorities of the Affordable Care Act, put its weight behind new payment models for healthcare providers, a sea change happened across the healthcare system. And don't know if anybody here is from Rhode Island, but we've had some amazing success in Rhode Island with our provider ACOs. This signaled to private sector stakeholders that payment reform was not going to be a passing whim, but it was going to be a lasting structural change on which they could invest and rely. That in turn buoyed these private sector alternative payment models and the good results we have seen. So that's all to say that the federal government is uniquely positioned to send a strong signal about the direction of payment reform. While the experiments we've heard about today are steps in the right direction, federal leadership will drive private sector momentum toward superior payment models. I encourage you to keep HHS and CMS officials apprised of your work and encourage them to engage on innovative reimbursement models for new therapies. I'd like to leave you with a final thought. I think we all agree that our current system lacks the flexibility to respond to the innovation we're seeing in curative therapies. However, the need to use these payment over time models to address that innovation makes a big assumption that, by definition, these cures should or must be fabulously expensive. Cures that bring extraordinary value to our medical system may well be worth a high price tag, but we've seen plenty of expensive drugs come to market that offer little to no improvement over existing products. Cell and gene therapies are expensive to test, manufacture, and administer, and their price tags reflect that. But they may not always be so expensive to create, and they may not always provide exceptional value just because they use exceptional new technology. So, as we restructure our payment system to accommodate these high-priced therapies, we also need to keep an eye out for the consumer and understand and remember that it is not inevitable that these cures have to carry astronomical price tags. Thank you for the work you're doing. I hope that we on the Senate Finance Committee can be a bipartisan friend to your efforts. Thanks so much.
Would you like questions? Would you like to take some questions? The senator says he's happy to take some questions if any of you are courageous enough to stand by a microphone to make them.
I hardly ever
Come
bite.
on, we spent all day saying that we needed some help. Who's going to say something? Otherwise, you're going to make me do it, huh?
Over here.
Over here.
Thank you again today for the great opportunity to listen to such great minds. Rick Pierce from Bioness Partners, New York and Paris. My question is, and I think it was articulated by a few of the panelists here today, that it's critical that we, in New England, for instance, that we don't stifle innovation, but we also have to deliver cures that work.
Yeah.
And how do you see that in your own state, which obviously could benefit tremendously from this area? What do you feel would be some good solutions?
It's hard to know because we don't have a established pathway for how this works, and we don't have an enormous amount of experience. Where we have had experience that comes immediately to mind has been with the hepatitis C treatments, which for a while were panicking our Department of Corrections because so many people who were incarcerated had that illness, and by virtue of being there, were entitled to treatment for it, and at the current price, you could do very simple multiplication and come up with a number that caused the corrections director to swoon. But what we saw was that once that was in place, innovation began to work on price, and that price began to come down. Different ways of dealing with the drug company emerged, and we're kind of, I guess, bumbling our way through it. But the directions when we bumble our way through it seem to be good ones. So I don't think we've drawn out of those experiences yet precise metrics and dynamics that we can articulate, but it does seem to just kind of work its way if, as Winston Churchill would say, you just keep buggering on.
So I'll leave.
So there's a little bit of optimism in that, even though I don't know that there's a magical method.
So I'll leave the group with one comment. The Orphan Drug Act obviously spurned a very important area of drug development, but it also created, with a lot of incentives. It would be interesting to see if we put some incentives for companies who developed more affordable orphan products and actually incent them to do that.
Yes, I think the idea that the government can separate the incentive for development of a drug from the revenue stream of that drug by providing upfront reimbursement for that innovation, I think is an idea very, very much worth considering. And frankly, there is a national public benefit from having those drugs out there that goes beyond just the individuals who are currently on the regime at any time. So it makes economic sense as well. Thank you.
So I'm not sure who's next, but
I'll just swap back and forth.
I could just take you in a slightly different direction using your Judiciary Committee hat on an issue of patent policy. As you may recall, one of the, I think is the director of PTO's hearing on the issue of subject matter patentability. We know now, and actually early in today's conference, people were suggested that it's really important in this area that diagnostic tests match up with these expensive therapies. And as you know, the Supreme Court case in May on Prometheus and then the Myriad case on affecting DNA technology, there's been a discordance with the US law on subject matter patentability in the rest of the world. President Obama's PTO director, David Kapos, now gives speeches that says that an NIH invention, certain NIH inventions have a greater chance of being upheld in patent courts in China than the United States. And as you know, there's been a great debate here. I know there's a new intellectual property subcommittee. I just wonder if there's any chance that we might be able to look at this vitally important area where it undergirds this whole realm of discovery.
Yes, and that is our job and our task, so do bring it forward. Chris Coons of Delaware is the Democrat on the IP Subcommittee in Judiciary, and I'm trying to think who the Republican chair is. It's Tom Tillis. So in addition to everything else, they're a good working team. So that's a committee that I think will be relatively effective. There was a TV show about a coroner, and all the folks are standing behind the coroner, and he pulls the sheet off, and everybody keels over. And I'm afraid that's the way Judiciary Committee members feel when somebody brings up an IP issue. Some issues are adhesive in Washington, and as soon as you touch one piece of it, all the other pieces flock and gather and aggregate until you have to deal with the massive issue. And then that ends up with a huge blowdown between tech and pharma, who have opposite views of which way things should go, and ultimately a standoff. But I think on technical things like this, there is a way to go forward, and I do have confidence in Tom and Chris. And I'm on the committee too, so don't hesitate to ask.
Okay, let's try to let some of the other people.
Happy to take it up with you.
I'm Krishna Komdar. I'm a physician scientist, and last year I led a professional society for stem cell transplant and cell therapy docs. And as CAR T cells hit the market, we were advocating for CPT codes and meeting with CMS and CMMI. And it struck me that there was this problem with slow evolving frameworks around DRGs and capitation that left us $300,000 or $400,000 short. We can't actually provide these to Medicare patients. And yet, you can't necessarily just say, well, this appears to be radically new or different. And I love what you said at the end about can't just assume because it's a novel therapy that sounds cool that we give it carte blanche. So how do we find this? The Medicare system is clearly too slow to evolve, especially around these novel technologies. And yet we have to find novel ways when we find a leap like CAR T cell therapy for B-cell malignancies. How do we balance those things, and when are we going to use our?
It's a really terrific question. I think a little bit I'll revert to my earlier answer, which is we kind of have muddled through. I do think that there is a structural problem within CMS when it comes to rolling out new programs like the ACO program for provider groups, for instance. And that is that to keep the peace in the large provider community, they tend to basically sprinkle what they're doing as widely as possible so that everybody gets a little bit of it and everybody's happy, which makes reasonably good professional politics, but doesn't necessarily encourage the kind of breakthrough behavior that we've been seeing. So I've been beating on them long enough to do what I say, feed the lead dogs. Not only do the lead dogs need to be well-fed and healthy and charging forward, but everybody else in the pack needs to say, whoa, look at how well the lead dogs are fed. I want to be like them. And too often the lead dogs are actually underfed, and there's been too little appreciation of the difference between a model and a ultimate product. Ford is designing a new car. It doesn't tell the people who are putting that new design together, that new experimental model together, that you've got to come in at the budget of the car that's going to come off the line 1,000 at a time. It understands that you invest more because you're doing something that's new and different, and you don't necessarily get your money back from the thing that teaches the lesson to you. And that has been the battle with the ACOs, and I foresee that same battle coming up here. So if you go down the halls of CMS yelling, feed the lead dogs, they'll probably think I'm there. But I do think that's something to watch out for, that they really need to be pushed to make sure that the reward of a new program is going to those who are really delivering innovation and not just everybody gets some because then everybody's happy and we get fewer complaints.
But the risk of
And this is
Mark's
not this
wrath.
administration, by the way. It was just as bad under the Obama administration.
One very quick thing, and that was
Yeah,
that
yeah.
when we met with CMMI and CMS officials, and I had somebody great from HHS approach me today. The CMMI said, "Oh, we totally get this, but our job is to do pilots and not to legislate solutions across the board." So even though they were like, "Yeah, we have ideas," you know, so
Yeah.
that's another
We try to
structural
keep them
problem.
talking, but sometimes we have to intermediate.
Exactly.
If we can help, let me know.
You deferring to the other side?
He was there first.
Okay.
Similar question, and I think we're going to get to the same muddling through answer, which is, you know, based upon everything we've seen today, obviously this technology moves faster than the ecosystem, the payment system it's in. What's the process-wise best strategic approach? Is it an incremental bolt-on in the kind of payment systems we have, or is there a path forward for something truly, you know, revolutionary to meet the truly different products that these things are, from political
I
perspective?
think usually a experimental model, a pilot of some kind, to try something with a few drugs or a few therapies and test the proposition before it's done across the board makes sense. It's also easier to get approval because there's less anxiety, and perhaps people related to that illness or that therapy can be convinced that this is a good thing and support it, so you don't have to get buy-in from the whole system. CMS is just so damn big that trying to move the whole beast is really, really difficult. So grab what you can when you can, and then use what you've got to argue for how it should be expanded. And then you'll have an evidence base to make the argument from.
Thanks.
Thank you very much. One more.
Thank you, Senator, first for being so generous with your time. I'm Nick Fiore from the Duke Margolis Center for Health Policy, and I had a question specifically about potential revisions to the anti-kickback statute. So as you yourself said in your comments, as well as there are many comments and kind of an emerging consensus from manufacturers, payers, providers, that to really test some of these new innovative contracting models, there might need to be some legislative change to the anti-kickback statute. Simultaneously, there is a lot of animus in the public about high drug prices. So what do you think are some of the successful ways that Congress, as well as other organizations, can talk about a potential thoughtful approach to addressing anti-kickback issues while also still inspiring confidence in everyday Americans that this could be a better deal for them?
That's a good question. The Stark laws, in particular, date back to the HMO model. And the HMO model was basically, we are going to screw you, the consumer, but we're going to make the doctors happy by paying them on the side for participating in the scheme. And it got so bad that I think you ended up with Denzel Washington in a movie, you know, taking on armed an HMO, and everybody in the audience rooting for the guy with a gun against the office full of people. So, you know, they made a pretty good-sized mess, and unfortunately, we are left with the residue of that for a while. I think that the ACO model, which needs to be better understood and explained, where you have to compete against quality metrics and produce results, and then you get to share the savings, and things aren't taken away from patients. In fact, in my experience, the good ACOs are actually adding services to patients because they can add inexpensive, high-touch, you know, valuable services at a lower cost than what they avoid in failing to do that, and somebody ends up in the ER and surgery. So the cloud of HMO land is lifting, but I think it's very important as kind of a baseline to say those were the bad old days, those are over. ACOs and payment reform and bundled payments and all that are a new and different thing, and we can provably show that patient satisfaction goes up, patient, you know, care quality goes up, outcomes go up, all of that goes up. And once people have made that mental transition that this is something different than those horrible HMOs, then I think understanding that the kickback rules aren't really pertinent any longer, in fact are actually harmful and interfere with the new model, is an easier case to make. And there are a lot of us in Congress who have already made that leap and understand that. So you've got a base to work with of people who are, concerned. At the moment, the anti-kickback laws and the HIPAA patient privacy laws have been have had some very unfortunate side effects and badly need to be reviewed. But they also have constituencies that put them there for a reason, and so there's a little bit of a third rail quality to them. The good news is that the Stark laws are, I think, less third raily than the HIPAA laws, but they're in kind of the same mode and should be thought of in the same way, and in some cases they actually overlap a bit. You can solve both together, and that's the solution we are actively talking about in the Senate Finance Committee. How and where do you do it, and who can we get buy-in from so that nobody accuses us of supporting crime? Get Mueller on the case. So thank you all for being here and for the work you're doing. It's very exciting. Everybody in this room is smarter than me, and I'm very glad to have had the chance to be with you. Take care.
Thank you so much, Senator. We really thank the senator for being with us, and we were fortunate to be able to share with him our suggestions for federal policy before he came here today, and he still came after looking at them. So we're very appreciative of all that. Thank you very much, Senator. And thank you, Anna, for all your help with all this. So just a few comments to close with. Today's been an exciting day where we've heard the promise, the challenges, potential solutions, two senators willing to help us move things forward. It's really up to us now as a community to engage and to push some of these ideas forward together and individually. So how might you do that through all this? Well, I've already mentioned a couple times that we have a great deal of thinking and publication, et cetera, that outlines all of this in greater detail. So your first area, should you choose to do it, is to learn a bit. And it's either online, it will be tomorrow. The website at which you registered will now convert to a website for conveying some of the information and what you've seen here today. Also on that will be an opportunity for you not just to learn, but to give us some feedback. Join our broader community and give us your ideas, what you thought worked really well, where are some obvious things we still need to improve and change, and how you might also like to help us as the larger focus collaborative to move forward. And then the final thing that we'd ask you to do is think about how you can be a champion within your own organization by taking some of these ideas forward, as well as you deal with those outside of your organization, how you can also champion this in coordination and collaboration with all of us in the room. It's been a fantastic day with all of you here today. We've had wonderful expertise. It's clear that the energy at the breaks and during the thing, as you came up to talk to the speakers, it's just infectious. It's an exciting community, a great time, and having innovation and financing for these, as well as the scientific innovation to help patients, are both crucial if we're to provide the access and the benefits that we all want to everyone. So thank you all for being here, and it's been a great day. Thank you again.